Welcome back to Your Health radio and television program. I'm Dr. David Morwood. I am a board-certified plastic surgeon, and I'm so happy you could join us today. This third and final segment for today's edition of Your Health will be Cleft Palate 2. I'd like to review what we discussed briefly in Cleft Palate 1. As you know, or most of you know, a cleft lip is the obvious split or division in the front of the face, in the lip, sometimes going into the nose. And of course, as we described in the Cleft Palate 1, on day number 28 in utero, the developing embryo is designed so the facial segments fuse on day number 28. That's actually quite early in the gestation process. That's before most women even know that they're pregnant. And so again, as we have discussed, the lateral or maxillary segments roll in from the sides, the frontal nasal process rolls down from the top, and on day number 28, they're designed to fuse just perfectly. So then the tubercle, or the red part of the lip, should be perfectly aligned, as is the white roll. That's where the red part changes to the white. In me, of course, with a mustache, it's not so distinguishable or obvious. But however, what we call the white roll is that junction between the tubercle, the red part, and the skin. The Cupid's bow is formed. That's that very gentle, very pretty line, excuse me, wavy line at the middle of the top lip, and then the philtrum comes together. That's the two little columns between the lip and the nose. And when something goes awry, on day number 28, a cleft lip forms. We've defined a cleft palate as a split or division in the roof of the mouth, which of course is the floor of the nose. There's the alveolar ridge where the teeth sit. There's the hard palate, which contains a very bony shelf in between the nasal floor and the roof of the mouth. And then, of course, there's the soft palate, which is towards the back of the mouth or near the throat. That's that little flutter valve, that's the little flutter valve that goes up and down and touches the pharynx during certain words that we say or in certain words that we form, like cookie or Coca-Cola, and is also very important in words such as papa or baby bouncing. That valve is very important, and it's designed to be elevated and touch the back of the throat, which is the pharynx, and controlling airflow between the nose and the mouth. And again, as we've said, there are a number of problems with a baby or a child that has an unrepaired cleft palate. Those being, they're slow eaters. The babies have trouble suckling or creating a vacuum as they're nursing. And of course, in third world countries, the mothers have a hard time spending all that time with the baby who's eating slowly. And oftentimes the milk will sort of come out through the nose and be regurgitated out through the nose. They have a hard time making the vacuum to suckle because that split or division in the palate won't allow a seal, and so the babies have velopharyngeal incompetence. And of course, if they can't make that seal, they can't make a vacuum. So they're slow eaters. They're prone to ear infections. Again, we've talked about that. The eustachian tube connects the middle portion of the ear to the back of the pharynx, and it opens up, and every time we swallow hard or perform a Valsalva maneuver, we clear the middle ear. Most of you have the experience of riding in a plane or going up a fast elevator in a very tall skyscraper where you feel that your ears need to pop. And the way we pop our ears typically is by swallowing hard or pushing. Well, again, a baby or a child with a division in the palate or a cleft palate can't effectively clear the ears. They can't effectively make that vacuum, and hence they're unable to clear the middle ear, and they get more frequent ear infections. The oral nasal hygiene is interrupted. Of course, we're not designed that saliva can go up into the nose, and the nasal secretions are not designed to come down in the mouth. So there's a difference in the oral nasal hygiene. There are, of course, dental problems. If the cleft of the palate extends to the alveolus, which is the ridge upon which the bones sit, of course the teeth are interrupted. And perhaps most importantly, babies with an unrepaired cleft palate have poor speech. those very important terms and phrases. They're called fricatives and plosives. Babies and children will have a great deal of difficulty forming certain words. And as we discussed, with an unrepaired unrepaired cleft palate or insufficient speech therapy, they will struggle to say words like Coca-Cola or bouncing ball, and it might come out like Coca-Cola or bouncing ball. They struggle to find other ways to divert the airflow away from the nose and towards the mouth, and vice versa. So that's an introduction to what we talked about, or a recap of what we talked about during Cleft Palate 1. Again, babies with an unrepaired cleft palate will demonstrate velopharyngeal incompetence, or VPI. And again, the palate is unable to come up and act as a valve to touch the back of the throat or the pharynx and control airflow. So what do we do about it? We want to close the cleft palate. So there's different terms from that. There's a palatoplasty. We can do a simple closure, or describe it as a simple closure of the hard palate and or soft palate. There's something called a pushback, where we elevate the soft tissues from the roof or the floor of the nose and actually push them back towards the back of the mouth, towards the pharynx. That way, when we do repair the split or division, as the palate elevates, it'll have an easier time touching the back of the throat or the pharynx, therefore inducing velopharyngeal competence. So the goal is to repair the split or division in the palate. It's to unite the muscles, to restore the nasal lining side, and to restore the oral lining side. So there's actually three different layers. There's the nasal lining side, there's the middle layer, which is the muscle, and there's the oral lining side. We like to reunite or reconstruct all three layers in a cleft palate repair, thereby leading the child or baby towards velopharyngeal competence. So how do we do that? I mentioned one way, that's called a palatoplasty. The pushback procedure is where we not only repair and unite the division, or unite the two sides, but also push it back towards the pharynx. We'll oftentimes use the term a furlough repair. Leonard Furlow is a genius plastic surgeon in Florida. I've been fortunate to work with him during my career. In fact, on a rotoplast trip, he came up with an ingenious operation whereby a Z-plasty is performed, actually two Z-plasties, one on the nasal side and one on the oral side. And the operation is designed not only to recreate or reconstruct the nasal lining and to reconstruct and recreate the oral lining, but to bring the muscles together and also simultaneously lengthen the palate, thereby bringing the palate closer to the pharynx, and thereby leading the baby again towards velopharyngeal competence. And again, as a baby is able to create a vacuum and form those words, then of course the velopharyngeal competence leads to fewer ear infections, better speech, and better feeding, and more rapid feeding. So the Furlow procedure is actually a way to carry out two Z-plasties to not only reconstruct and repair the cleft of the palate, but to lengthen the palate as well. So what about a fistula repair? Now, sometimes, unfortunately, in spite of our best efforts, a fistula may develop. Now, fistulas can occur in many areas of the body. A fistula is an abnormal opening or connection either between two body cavities or between a body cavity and the outside. Now, if there's an area of breakdown, typically at the junction between the hard palate and the soft palate, again, that's at the junction of the hard roof of the mouth and the soft part of the palate, that's an area where there's a tendency towards a little bit of breakdown. If there's some suture separation or some wound separation, a fistula can occur. Now, if the fistula is small enough, it's no problem, it doesn't bother the child, and they can occur in all areas of the palate, the soft palate or the hard palate or at the junction. But when they're large enough to, again, interfere with airflow and make it difficult for the baby or child to swallow without milk going into the nose or coming out the nose, then they need a repair. And that's called a fistula repair. And they can be very technically challenging because they're difficult oftentimes to get to mechanically, surgically, especially the ones that are far anterior. They're very hard to reach. And of course, there can be a lack or a paucity of healthy, robust tissue that can withstand a surgical manipulation. And of course, there's scar tissue there and very thin tissue, and it's difficult to manipulate. So if at all possible, of course, we would prefer that the cleft palate repair would be hardy and hardy and withstand all the physical challenges of swallowing and eating from the point on after the surgery. But a fistula can occur with any type of cleft palate repair that's chosen. Now, what about a pharyngoplasty? Again, in spite of our best efforts of repairing the palate, oftentimes we will recommend to a child who has poor speech a pharyngoplasty. There are many muscles in the back of the pharynx. There are muscles that elevate the palate called the levator palatini. There's the palatopharyngeus. There's different muscles there that actually help with the sphincter action. So as the palate comes up and elevates towards the pharynx, again, I've talked about it serves as a sort of flutter valve. When that works, it's great because there's velopharyngeal competence. But a pharyngoplasty will actually rearrange the muscles and the tissue of the pharynx to bring the pharynx closer to the palate, thereby either with some muscular action, bringing the pharynx closer, or actually helping the palate to touch the pharynx itself. So the goal of a pharyngoplasty is to bring those structures together and to sometimes improve the muscular activity or the muscular function. That's called a pharyngoplasty. And there's many different ones. There's the Orticocheo, and I've had the pleasure of working with Dr. Orticocheo. There's the modified Hines and there's the Hines. There's different designs, but the goal is the same, to bring the palate and the pharynx closer together and or improve the muscular activity. Now, a pharyngeal flap is a relatively complicated operation where some of the tissue from the pharynx is actually transposed and attached to the palate itself. There's different ways to do this. There's the superiorly based pharyngeal flap, the inferiorly based pharyngeal flap. That's when we actually lift tissue or raise tissue from the pharynx itself, transpose it, and attach it to the soft palate. Now, what that does is markedly decrease the airway, markedly decrease that space where air can go either through the nose or through the mouth. That will oftentimes cure or certainly dramatically decrease velopharyngeal incompetence, again, leading a baby or child who's in speech therapy towards velopharyngeal competence. Now, what about anteriorly towards the alveolus and towards the teeth? We'll oftentimes schedule a baby for an alveolarplasty and sometimes an alveolar bone graft. If the cleft palate extends to the alveolus, or that ridge anteriorly where that sets the foundation for the teeth, if there's a split there, then of course we need to repair that. And the repair needs to be bone and soft tissue. Different plastic surgeons have different approaches. Sometimes we do the soft tissue only at first and then do a bone graft. Other times we do the bone graft and the soft tissue at the same time. But that's a way where we repair the cleft in the alveolus. That's called an alveolarplasty. Sometimes we'll do the bone graft. Finally, babies with cleft palates will oftentimes need ear tubes because of those frequent infections. And again, the last operation, at least I have time to discuss today, is called a Lefort osteotomy. Oftentimes the bone itself, the maxilla, which is the upper jaw, will need to come forward. That's called a Lefort osteotomy, where we actually make a division in the bone and we bring that bone forward and secure it with plates and screws. It's either that or an Abbe lip switch operation, where we'll sometimes borrow tissue from the lower lip and transpose to the upper lip, thereby giving a more harmonious relationship and a more good-looking relationship between the upper lip or the maxillary segment and the lower lip or the mandibular segment. So those are different ways, either with a Lefort osteotomy to bring the maxilla forward, or with an Abbey lip switch operation. Those are different ways to not only give a better appearance, but sometimes help in function too. So again, the care of a cleft palate and the care of the child with a cleft palate is quite complicated, and that's why oftentimes we'll have a whole team assembled. We'll have an oral surgeon, a speech pathologist, an ENT surgeon, orthodontist, etc. And we all work together for the betterment of the child. Thanks very much for being here with me today. This is Your Health radio and television program. I'm Dr. David Morwood. I'm a board-certified plastic surgeon, and I'm so delighted you could be here today. Thanks very much for joining us.